Actually, they say 50% of childhood cancers go undiagnosed. Yet every 3 minutes, a child is diagnosed with cancer.
Every 3?
Globally, yes.
So how was that now? How was that coming home? What happens when you come home?
Remember, I don't have a job.
Ooh.
Right?
I forgot that bit.
But I am so motivated at Hope for Cancer Kids, and I feel like I've been given the right tools to be able to take this organization to the next level. So I went in 100%. HTK didn't have any staff. There was like one volunteer, and then the board. So to give you some context, at Hope for Cancer Kids, we have several programs or several areas of impact or our pillars. We create awareness, we provide access to treatment, we do capacity building, we do research and advocacy. Now, one of our main pillars is our health insurance support program. Back then it was NHIF under the National Health Insurance Program, and we were supporting kids from low-income backgrounds that could not afford to pay for the national health insurance, and we would pay for them so that they can get treatment in public hospitals. And at that point, we were supporting about 15, 16 kids per month. This was December 2016. No, this was now 2017. No, when I joined December 2016, we were supporting 16 kids. Then, I go to the US, I come back. 2024.
No, 2024 is...
2024, when we switched from NHIF to the Social Health Authority.
Sure, yeah.
And we were supporting over 450 kids per month with health insurance. Just health insurance alone.
Okay.
NHIF.
And is that monthly contributions?
Yes, we pay monthly.
Okay.
So we work with the different hospitals, and we work with the social work department, we work with the nurses in charge, we also are in touch with the pediatric oncologists. And they tell us, these are the children who have been diagnosed with cancer and referred to us. These ones are from such low income backgrounds, they don't even have fare, transport, to get from their village to Nairobi, let alone paying for the health insurance. So then, those are the children we onboard on our system. And we had our own NHIF number, now we have our own SHA, Social Health Insurance Fund number. Just like any organization pay for their employees, we have our number as Hope for Cancer Kids.
And you can pay your...
And we enroll those kids, and we pay for them.
Okay, I'm going to take this thing slow so that we move on with everybody who's listening. Whether from local, whether from Kenya, whether from abroad. Okay, number one, you've got kids who are not onboarded at the time on NHIF.
Yes.
Meaning the government can't pay for them the treatment and because they don't have this thing. So they can't get access basically to healthcare.
Access to treatment.
We're not even talking about them doing what you did, paying for yourself.
Yes.
Or we're not even, medical insurance is not even anywhere near them.
Yeah.
Their version of getting medical insurance is through the government, but then they have to pay this 500 shillings a month.
Yes.
So they're so poor, they can't afford this.
They cannot afford it.
Now you've even entered another tier group, and this one is now the scary of the two. You know, sometimes we forget that cancer is a journey. For yours was short and yours was a year, but that was short. And I like the way you talked about how you'd spend Monday to Friday. So I'm going to just use your story in context of another kid. So if they get diagnosed, their whole life changes.
Yes.
Meaning they have to be coming every single day.
Or they have to come and relocate to Nairobi. So how Kenyan hospitals are set up in the public space is from level 1, which is just basic primary healthcare level, all the way up to level 6, which is a fully equipped and resourced hospital that can comprehensively treat and diagnose.
Okay.
Let me talk about cancer. So what happens is, if you are suspected or confirmed to have a cancer diagnosis, they send you to a level 6 facility, because none of the other facilities can comprehensively even diagnose. Some of them cannot even diagnose, because you have to have a pathology lab where they do all their lab work to make sure that this is cancer, looking at it under the microscope and blah,
Yes.
blah, blah. They have to have radiotherapy machines, linear accelerators. They have to have pediatric oncologists. They have to have, and most don't have, some just have general oncologists. So
Pediatric
only the level 6
oncologists
facilities.
are children oncologists.
Pardon?
Pediatric
Yes.
oncologists. Are
It's like a
oncologists
pediatrician treats children.
Yes.
So a pediatric oncologist is a children's cancer doctor. Yes. So whenever someone is diagnosed or suspected of having a diagnosis, they are sent to 2 facilities. Initially when I joined, that is Kenyatta National Hospital, our biggest referral hospital in Kenya, which is here in Nairobi, and Moi Teaching and Referral Hospital in Eldoret.
In Eldoret, yep.
For the longest time, it was just those 2. But even the number of people being referred to Eldoret were much less than the ones coming to Kenyatta
Nairobi.
Hospital because of capacity, and for many other reasons.
Even location.
Yes.
If you're in Mombasa, it's shorter.
Yes, exactly. So you're referred to one of those 2 hospitals. So we treat kids, we support kids from all different areas of the country. You can be from Mandera, you can be from Isiolo, Kilifi, Bungoma, Kisumu, Nyeri, but the minute you are diagnosed, you're sent to one of those 2 hospitals. So that is why for the longest time, we started working just with those 2 hospitals.
Okay.
And you realize that these guys have nothing. This is somebody who comes from such a low-income background that, as I said, they don't even have transport to get to Nairobi. They get to Nairobi, they're told, you have to go see a doctor. Okay, I'll be here for a couple of days, I don't have money. Or you're told, you're here for a 30-day radiotherapy cycle. It's an outpatient procedure. Where am I going to stay? What am I going to eat? Let me go back and sell some cows or look for money. I'll come back when I'm ready. And they disappear. And they only come back when the cancer has advanced, to a stage where it's almost incurable. So that's the model we have at Hope for Cancer Kids. Ideally, access to treatment is one of our biggest pillars. Because if you cannot access the treatment, let me rewind. Cancer is a disease like any other disease. If it is caught early and you have access to treatment, you have a good chance of beating it. A lot of the issues we have here is that people come very late. There's late diagnosis because there's a lot of misdiagnosis. Imagine starting in a dispensary in Mandera,
Being told
where the primary healthcare worker is maybe just a county health officer who doesn't have the know-how, the training to suspect this might be cancer. So they'll treat you, they'll try. If they can't, they send you to a level 2. That's how they're trained. If level 2 tries, they can't manage, they send you to a level 3. By the time you get into a level 6, you could be in the system for a whole year. So that's delayed diagnosis, misdiagnosis, and coming at a late stage. The cancer is detected or found late. So because of that, the chances of survival are also very low. If I can give you some statistics, in the childhood cancer space, if you go to high-income countries, USA, Europe, all high-income countries, almost all, survival rate is 80 to 90% for childhood cancers.
What?
For childhood cancers. In Kenya, we're at 20 to 30% survival.
So 80s.
Not because something can't be done, because it's being diagnosed late, then they don't have access to treatment because they can't afford it. So people are dying not because it was too late, not just because it was too late, but also because they had no way of accessing the thing that would help to treat the cancer.
You know, when I hear your story was the perfect setup for the conversation that we're entering into. Because you were misdiagnosed.
Yes.
Not once, not twice, not
Yes,
three
it
times.
took 6 months for me to get a proper diagnosis.
6 months?
Yes.
With
Going to the best hospitals in Kenya.
No, Sido, this is insane. You with the access and quote unquote privilege that you have,
Yes.
took you 6 months.
Yes.
I mean, even when you got referred to the right place, you met the wrong person in the right place.
Yes.
Meaning you left with the wrong thing.
Yes.
Again, you've got a nosebleed here, take this, I'll come back after 15 days.
Yes.
It wasn't until you met the right person in the right place, hence why you're here.
And I could afford to go to that right person, pay the consultation fees, do the MRIs, do the X-rays, do the blood work, which are out of pocket, and then go back for my results.
And you're in Nairobi.
Yes.
Even with all of these things, if you were in Eldoret, if you were in Nyeri, it would have been still very difficult for you.
Yes. You might even have just been referred to Kenyatta Hospital just to do the diagnostics. Maybe we don't have a pathology lab here, so we can do the biopsy, but we cannot look at the thing under the microscope because we don't have pathologists. We don't have the right equipment in the lab. So just go to Kenyatta Hospital for the test. Not for treatment, for the test to see what's wrong with you.
Okay. I haven't understood the privilege of even just being in the capital city.
Yes.
Which is Nairobi. Then the privilege of having the finances to be able to do this, even though we know it's expensive. Meaning, okay, so what you're saying Hope for Cancer Kids does is, number one, let's ensure that these guys have access to SHA now so that the government can pay for their medical.
Yes. In other words, we are breaking down all the barriers to accessing treatment.
Okay.
So they cannot afford treatment, we'll pay for their SHA. Or he's coming from Kisii to Nairobi or to Eldoret, he does not have transport. We pay for their transport. He's coming to Nairobi, let's say even just for his normal checkup or his diagnostics, to do his tests. This person does not know where he's going to stay, what he's going to eat. They already come from an impoverished family. So we have an accommodation center. So when people travel 300-400 kilometers to Nairobi to access that treatment or care, they don't have to worry about what they're going to eat, where they're going to stay. What we're trying to do is ensure that these people have uninterrupted treatment so that we can increase their chances of beating the disease.
Oh my God. Sido, me and Aizo, who are here, we had the privilege of interviewing a lady on this show called Julie Boyd. And they're building a hospital in Eldoret.
Yes.
And we went around seeing people getting palliative care. But then one of the buildings that they showed us was a place called Micah's house. And this story is I'm going somewhere in relation to exactly what you're telling me. And I did not understand that house. And she kept explaining it, and I couldn't understand. Because what they do is, that building was for people to come and sleep.
Is it called living room?
Yes, living room.
Yes.
But now that building was called Micah's house.
Yes.
And the living room.
Yeah.
It was for people to come and sleep. And I was like, why are they sleeping? It's like because they come with kids from all across places to
Western
Eldoret.
Kenya, yes.
So they can sleep here because then they ferry them to Moi Referral Hospital.
Exactly.
Now, you're saying, now that's Eldoret.
Yes.
In Nairobi, a mother comes with her 7-year-old from, let's say, Mtitoinde. You guys, is it only for the child or for the child and the mother? Because the child is not coming alone.
We cannot accept a child alone.
Oh.
We're not a children's home. They have to come with a caregiver. And 9 times out of 10 is their mother. I'll go into something else, off tangent kidogo, but we'll come back to this.
Okay.
Some of these myths and misconceptions about cancer, whether cancer is a death sentence or it's a curse, or we didn't have cancer in my family, or this child is dying anyway, we have 5 other kids in the village. It's okay, he's going to die anyway. Let's take care of these other kids. Now you're moving from a 2-income family, even though you're not earning much, to a 1-income family, because the mother becomes the primary caregiver.
Oh my God.
This has brought so many rifts in Kenyan families. We have so many cases of mothers who are abandoned with their sick child.
Yeah.
There's a case of a lady who was abandoned with her son who had cancer and his older sister who was fine. And the husband said, this thing, forget about the treatment. That kid is dead anyway. And she said, I'm not leaving my child. We have to try. And the minute she said, I'm going to Nairobi for treatment, he abandoned her completely. She used to run a restaurant. So now she's jobless. She's homeless. She has a child with cancer, and she has her other kid. And she had to find a place to leave her other kid with one of her relatives to bring the boy for treatment. The first time she came to Nairobi, when she went back, she couldn't find her daughter.
Yeah.
It took her a week to find her daughter, because even the relative had just given up. You reach a point where she has nobody to call, and she was introduced to Hope for Cancer Kids, and we held her hand from the beginning. This boy is a fighter. He had 3 different kinds of cancer. He finishes one, another one comes. It manifests somewhere else. Another one comes. This boy is now in school. He's doing well. He's fine. He has gone through his treatment. We held her hand from beginning to end. And another thing we do is those strange calls in the middle of the night. We have a team that deals directly with the parents, and they get calls at all sorts of hours. This is happening. And sometimes they just want someone to listen. They know we are not doctors. They know we can't prescribe medicine or tell them this or that, but sometimes they just want someone to listen. Sometimes they're like, I was told this chemotherapy. What is chemotherapy? Sometimes it's, I don't know how to do this boy. He's, his siblings are upset with him because all the money is going towards his treatment, which means they're not getting anything. They're not getting new school shoes every term. They're not getting, I don't know. So there's that resentment between even the siblings, because they don't understand. Like, look, before, we were all getting, school shoes. We were all getting this. But now all of a sudden you're sick and everything is going to you and we're getting nothing.
Oh my God.
So this lady, she's strong. But the boy is now doing fine. He's back in school and loving it. He's thriving after going through 3 different types of cancer. So I was just trying to bring in some of the other aspects outside of just the treatment and the disease that these families go through.
When you've talked about, Sido, your story is the perfect setup for this. First of all, my mind it's been hit with a lot. So you get cancer, you fight through it and win it, but it brings on this new complication, which is hearing. Mm-hmm. This family, a child in a family gets cancer or is diagnosed, and it suddenly brings about divorce, separation. I mean, you don't even know what's happening with the other children.
Yes.
It's not just this disease that it comes with. Joblessness. You know,
They actually say with a cancer diagnosis, especially in low and middle income countries like Kenya, a family moves from a situation of poverty into extreme poverty.
wow. Okay. Okay. I've understood. I liked what you said again. Access to affordable healthcare. Access to healthcare. You say it in your words. What does
Access to treatment.
access to treatment? That's what Hope for Cancer Kids does.
That's one of our main pillars.
That's one of your main pillars.
Yes.
What other pillars do you have?
Awareness. We create awareness. We create childhood cancer awareness because, as I said, there are myths and misconceptions. Cancer is a death sentence. Children don't get cancer. Your child got cancer because you're cursed. Your ancestors must have done something wrong. Or you did something bad and God is punishing you. Or, let me go to the traditional healer, the mganga, or let me go to my pastor and he'll pray for me and tell me I'm healed and, that's it.
Yeah.
So you find you have to create a lot of awareness to tell people cancer exists. It is a disease like any other disease, and there are treatments that can help you fight this disease. And if it is caught early and you have access to treatment, you need to seek treatment. It can be beaten. However, also, you have to train the primary healthcare workers. The first point of contact is not going to be a pediatric oncologist in Kenyatta National Hospital. It'll be someone working in a dispensary in Isiolo. So we have some programs that we have tried to help raise awareness, working in conjunction with the Ministry of Health, National Cancer Control Program, National Cancer Institute, where we are trying to raise awareness about childhood cancer, both for the medical professionals and also for the general public. So we help raise awareness because if you're able to tell these mothers, for example, there's one kind of cancer called retinoblastoma. It's an eye cancer. It manifests in the eye. It's one of the only childhood cancers, I think it's the only one, that can be screened for. If you shine a torch in the eye, you'll see a glint. There'll be something you see in the eye. And you can tell, okay, there's something wrong with this eye. Go get it checked out, right? If these mothers do not know, if I see this thing, or if the teacher who spends most of the time, if I see something in the eye, I need to make sure this child gets checked. Where do they go get checked? What do they go get checked for? What do they tell the doctor when they go to the hospital? So unless you create that awareness, people will not change their health-seeking behavior. Because a lot of the time, you wait until you're almost incapacitated before you go to the hospital. Because you're from that environment where I don't even have time to take off my job, to look for extra money, to go and take this child to the hospital, to find out what's wrong with this eye. So we create a lot of awareness. As I said, we provide access to treatment. We also, and by access to treatment, that also involves transport, accommodation, from where they're coming from to Nairobi for their very needy cases, and also from our accommodation center to and from the hospital every day, right? We're providing that accommodation. We're walking them through the journey. We also do capacity building in terms of the caregivers trying to, number one, mentally walk them through the journey. We provide psychosocial support. We provide psychological support to the children. Like every Thursday, we have art therapy sessions at Kenyatta National Hospital in the pediatric oncology ward. It allows them just to be kids. Imagine your whole life for the last 2 years has just been injections. You see your mom like twice a year. It's just injections, surgery, radiotherapy, chemotherapy, So we are trying to provide them a break from the battle. One, to allow them to be kids, because they've been isolated from their family, isolated from their siblings, their parents. They are no longer in school. They're isolated from their community, their neighbors. They are now in Nairobi doing treatment. Some of them are in that ward for a year without going back home. All right? So we wanted to give them, one, an opportunity just to be kids. Draw, paint, paper mache, all those things we did. And then secondly, it's almost therapeutic for them. Thirdly, it's something consistent. A lot of people will come to the ward, hand over toys or care packages, and you won't see them till next year, Christmas. We are that constant. They know every Thursday we are going to be there. They look forward to us, they know us, they love us, we love them, we know their stories. Sometimes they tell us, can you call my mom so I can talk to her? Just small things like that. And somehow you realize that some of these kids end up hitting developmental milestones. Some of these kids, for example, have never held a pencil. Maybe if they are diagnosed at 3 or 4, they were not in school. But now they're coloring, they're painting, they're doing things. So by the time they're finishing that cycle of treatment, they can hold a pencil. They can write their name. They can paint something. These kids are out of school for even 2 years. So at least you're giving them that, hitting those developmental milestones. One of the things we want to do in the future is start a learning program so that when these kids are in our care, we can partner with some teachers to be able to at least, you can't do it like grade 1, grade 2, grade 3, but at least you can give them some educational activities to do to keep their minds active, even while they're in that state. We also do a lot of advocacy. We are represented on various technical working groups of the National Cancer Control Program. The first National Cancer Control Strategy did not have a section or even the word childhood cancer in it. The current one, which was released last year, every pillar of the National Cancer Control Program now has a section on childhood cancer. We advocate for child-friendly policies, and we try also to be, I wouldn't say the devil's advocate, but to tell it like it is. If there's an issue, if there's a drug stock out, if the radiotherapy machines are not working, if people are being told to pay out-of-pocket expenses that they didn't have before, we are trying to ensure that these people have a voice. A lot of these people are not educated. They do not know their rights. They do not know that they have a right to question or query or even get a second opinion. So we try to be their voice, to kind of highlight the gaps in the healthcare system so that things are done to reduce those gaps. Now, before we used to do it as a them and us. Government is not doing this, they're not providing this, they're not paying for this. But we realize that we all have the same goals and we all want the same outcomes. Better survival for these children to have early diagnosis and access to treatment. So we realize that we're actually partners. All of us are partners in this. So we don't make noise to make the government look bad. In fact, we work very closely with the government institutions to be able to highlight these gaps so that they can be addressed. Yes. In a nutshell, that is what we do. All we are trying to do is ensure, okay, from my perspective as Sidney, I've gone through this. I had a family that could provide. As much as it was tough, they were able to, come up with the money for me to go through my treatment. Whether you're born in Timbuktu or Nairobi or Adelaide, Australia, or Washington, D.C., I want every child to have the same opportunity I had to beat cancer.
Let me ask this question. The first element that you talked about was accessibility. And right now, if a kid in Magadi is diagnosed with cancer and they don't have health insurance, the SHA, and you pay the 500, will they get access?
Yes. SHA is a bit more complicated than NHIF. NHIF, they were paying 500 per month. Now with SHA, when you're registering with SHA, you answer a couple of questions, and then they put you in a bracket. So the lowest amount, I think, being paid is 300 bob. The highest that we have seen is 1,200 per month.
Okay.
So the average right now for SHA is about 700 bob. So what happens is, if you have you've paid your SHA and it is up to date, there's a certain amount of treatment that you'll be able to get through the government. Yes? And it's almost, if it is caught early, it could cover even 100% of your treatment. Because the earlier it is that you catch the cancer, the cheaper it is, the more cost effective it is to treat. It's not as intensive, the doses are not as high, so it's actually not as capital intensive if you catch it early. If you have that, your social health insurance fund up to date, you can get access to treatment in public hospitals, in public institutions.
Because now I'm talking about the kids here.
Yeah.
You get, so the people who you're talking about didn't even probably know this thing exists.
Yes. And you see, some of these guys...
Is it connected to the mother, to the parents, and then to the child? Or is the child a standalone?
For NHIF, before we switch to SHA, obviously you cannot register a minor.
Yes.
So you have to register them under the parent. And what would happen is we would register them under, let's say, the father, and they get through to a certain level. And if that amount depletes, you then register them under the mother. So they're almost getting double for your trouble. And that could even cover 100% of the treatment, a lot of the time. And depending on the stage that you are diagnosed at. With SHA, you cannot do that. It's per family. Right? So you can't register under the father, then under the mother. It's per family. The government, on paper, has increased the amount they were giving, the cancer package. On the ground, there are still challenges. We switched to SHA in September, I think, 2024. 2024, our average was 471 kids per month, the average, monthly premiums. When we switched to SHA, there were a lot of teething problems. Our numbers went down to 5 children per month. Where are these kids going? They can't access treatment. They're told there's this copay. They're told the system has changed. They're told this, they're told that. So eventually, after the teething problems, our numbers have started growing. We have passed the 200 mark right now, of 200 kids per month, but it's still way below what we were doing before.
So what happened to the other kids?
That's what we don't know.
Oh my God.
But we are trying as much as we can to even reach out to, our previous beneficiaries to find out, are you guys okay? Is everything, what's going on? But also we work very closely. We get all our referrals from the public institutions.
Okay.
Yes. Directly from the public institutions.
So,
we don't take walk-ins.
So Nairobi Hospital, Kenyatta Hospital, for example, calls you and tells you about a situation that is there.
Yes.
How big is your team? That laughs, is it?
Before I answer that, there are 2 ways we get our referrals.
Sometimes I say, we are CTA,
And it's we. So how we get our referrals, as I said, we work very closely with the social worker department, the nurses in charge, and the doctors in the hospitals. Some institutions will say, this is our list for the month. From last month, these are the ones we're removing. These are the ones we're adding this month. Some have passed on, some are not on active treatment, some have completed treatment, some have passed on. So every month we reconstitute our list of children we are paying for. The other way we do it is sometimes we go into the hospitals to do our rounds, and we're by the way, please talk to this mother here. The nurse will tell us, please talk to this mother here, she needs assistance. Please talk to this mother here, she needs assistance. Please go to the social work office. I think there are 2 kids that were supposed to be coming for clinic, but they're not coming. Please find out what's happening. So those are the 2 ways. Those are the ways we get our referrals. I forgot your second question.
No, that's...
Your actual question.
Even I forgot it. But what you've brought up then brings up a different conversation, because we're still just at the point of accessibility. First question you answered was, if a child just comes in
Yes.
and you pay today, can they get treatment? And the answer I'm hearing, at least, which I'm very happy for, is yes.
And not only that, with the health insurance, SHA, and even NHIF, there was usually a waiting period. With NHIF, I think there was a 3-month waiting period from the time you pay to the time you can access the treatment. From the time you pay your 500.
3 months.
Yes, there was a 3-month waiting period. So in those 3 months, the cancer is progressing, right? And some of these cancers in children, because
They're
I'm
growing.
not sure if it has something to do with their growth hormone or what it is. Some of them can double in size in a week, depending on the type. Some childhood cancers are very aggressive. So we have a very good relationship with the hospitals we work with, and it reached a point where the hospital would get a child. This person has never been enrolled. Their parents don't even have IDs. So it's a whole process before you even know. But they know this is a hope for cancer kids' child. We know they'll pay. Start treatment immediately. So that's another barrier we were knocking off.
You know, sometimes we blame the institutions, aka the medical institutions, but they need to follow protocol, or they need.
They're doing a very good job in a very resource-strained
Yes.
environment. Almost 3,000 children, over 3,000 children are diagnosed with cancer every year in Kenya.
3,000.
Over 3,000. Where do these children go? These are the new diagnoses, not the ones already on treatment. So you find Kenyatta Hospital, our biggest referral hospital, our biggest public referral hospital, is getting so many people coming in because no one else can. So it reaches a point they are limited in what they can do. They might not have enough pediatric oncologists. They might not have enough radiotherapy machines. They might not have enough trained specialists, enough pathologists. They might not even have enough room to accommodate all these people. But they are doing the best they can with what they have. A lot needs to be done. But they're also doing a very fantastic job. To the pediatric oncologists, the nursing team, the administration, and also a Moi Teaching and Referral Hospital in Eldoret. The same, in the public system, a lot of the issues we have are because the resources are very strained. So they can only do so much with the little they have. Every once in a while you hear of stories of, corruption or this or that, but in general, they're doing such a good job. They have come such a long way in terms of the quality and quantity of care. They're developing other institutions like Kenyatta University is now also a level 6 hospital.
As of now?
Yes.
So we've got more than 2 now?
Yes. Garissa is also on course to become a level 6 facility. They have a cancer center, they have radiotherapy machines, they have... one of their biggest concerns is actually just trained personnel. Are there enough pediatric oncologists? So when the children need specialist interventions, they need to actually refer them, even though they have the equipment. They might not have the HR.
I get it.
Or the trained technicians to work the radiotherapy machine. Nakuru is also on course. I think they launched a cancer center and they're doing a good job. So I think the government is also trying to decentralize cancer treatment so that you have not everyone has to come to Nairobi or Eldoret. You can go to Nakuru, which will reduce the catchment area for Nairobi and for Eldoret. You can go to Garissa, which has a huge catchment area. I mean, between Kenyatta, KU, and Garissa, there's nowhere else, there's no other level 6 hospital.
Wow. So even that number 3,000, maybe that's the only number that we know because of the ones who've maybe made it somewhere.
Actually, they say 50% of childhood cancers go undiagnosed. Yet every 3 minutes, a child is diagnosed with cancer.
Every 3.
Globally, yes.
Okay, let's take a break, but I want us to continue this conversation because I want to now hear about the second pillar of access, which is accommodation. Okay, we'll be back in a bit.